The topic of today's lecture is Behcet's syndrome. So let's get on with it. So Behcet's syndrome is a multisystem, both autoimmune and autoinflammatory disorder, and it is usually found in patients who are found in either in the Mediterranean region or in the Middle East region or even in the Far East. So all those countries and regions which were around the historical Silk Route region, that's why it's also called the Silk Route disease. And it is more common in the area which is nowadays known as Turkey and its surrounding Mediterranean areas. Now, Behcet's disease is usually manifested as mucocutaneous ulcers, which are usually found in the oral cavity, around the genitals, sometimes even the eye involved, with some corneal ulceration, scarring of the sclera. And as for its epidemiology, usually male and female population are equally affected. The only difference is that the male population has a more severe type of manifestations, that it affects the males in a more severe and painful manner. So, like I said, Behcet syndrome is categorized by mucocutaneous ulcerations. And the most common of these manifestations are the aphthous ulcers that are found inside the mouth. Now, aphthous ulcers are those ulcers which are found in the oral cavity which do not have any underlying hard tissue or bone. So these aphthous ulcers are usually found either in the buccal cavity, in the skin underlying the cheeks, or in the lips. So the areas around the palate, in the posterior region of the oral cavity, those regions are usually spared. So aphthous ulceration is the most common manifestation, to the point that it is considered pathognomic, that you cannot diagnose Behcet's syndrome without first having some kind of clinical manifestation of these aphthous ulcers. So in this picture, you can easily appreciate that this is an aphthous ulcer of a patient around the angle of the stoma. This is a very typical aphthous ulcer with a central necrotic tissue, round oval margins, and these are the kind of the ulcers you will usually find. Next, we're going to talk about the pathogenesis of the Behcet syndrome. Now, we do not know the exact inciting event or what exactly triggers the onset of this disease. Like I said, that this disorder is both a mix of autoimmunity and autoinflammatory changes. But we do know that genetically, HLA P51 plays a crucial part. So all those which present with HLA-B51 are more prone to having this disease, along with those patients which produce antibodies against this enzyme called alpha enolase, which is usually found in the endothelium, or selenium binding protein. Now, all those antibodies, when presenting in the body, produce a specific immune response. So all these circulating antibodies start to attack the alpha enolase enzyme found in the endothelium. So the endothelium starts to undergo changes, and these changes then manifest as non-specific inflammation. Now, this non-specific inflammation in this case represents systemic panvasculitis. That is, there is general inflammation around the vessels, and there's also neutrophilic migration, neutrophilic infiltration, along with endothelial swelling or the edematous changes around the endothelium. So whenever these events happen, so we get certain migration of certain cells such as the T helper cells 1, helper cell 17, cytotoxic T cells such as CD8, and all of these cells along with the neutrophils secrete certain chemokines, and these chemokines such as IL-10, IL-23, IL-32, all of these then further trigger further migration of both the neutrophils and all of these T lymphocytes, both the helper ones and the cytotoxic ones. So we get the activation of the cytotoxic T cells along with further production of autoantibodies that are already being produced. So this creates a kind of a cycle that the antibodies being produced by the B cells here then cause the immune system to respond in a way to produce the anti-enolase antibodies of the endothelium, which then produces the non-specific inflammation, the panvasculitis, which then starts to employ other cells, the T cells and the cytotoxic cells, which then, after their activation, secrete more of these chemokines, which then involve more of these cells. And as that cycle turns into a vicious cycle, the endothelium starts to disrupt. And as the disruption of the endothelium extends, it's turned into an ulcer. And this ulcer on the mucocutaneous surface is what gives us the characteristic symptomology of the Behcet syndrome. Next, we're going to talk about the clinical manifestations which are oral. Now, as for the oral manifestations, like I said, first of all, the aphthous ulceration or the aphthous ulcers. And the aphthous ulcers are found around the lips, inside the buccal cavity, because every mucosal membrane inside the oral cavity, which does not have any underlying bone, is prone to having any kind of aphthous ulcer. And these aphthous ulcers are characterized by oval or round margins with a central yellowish necrotic tissue. And usually these are of small ulcers, usually less than 10 millimeters, but larger herpetiform ulcers do form. And whenever these both the aphthous ulcers and the herpetiform ulcers starts to form in the oral cavity, this leads to ulcers being painful. So the painful ulceration inside the mouth, either they being the aphthous or the herpetiform, this condition or this manifestation is pathognomic for the Behcet syndrome. You cannot diagnose any patient without this presentation. Next, we're going to talk about the other manifestations. Like I said, it is characterized by ulcerations in both the oral cavity, the genital areas, sometimes even the eye is involved. So, in general, we can say that the mucocutaneous surfaces are involved. And in about 80% of the patients, we also find skin manifestations. And these skin manifestations are usually presented as a folliculitis, that is the base of the hair follicles that is inflamed, and sometimes these folliculitis turns into fruncles. Then we have the erythema nodosum. Now, erythema nodosum is a condition where round nodules which are red have a marginalized, well demarcated rash start to appear specifically on the limbs and sometimes on the trunks. Then we have the manifestation of acne or acne-like manifestation. Now, it must be noted that it is not true acne, only that the pustules resemble the manifestation of a typical acne. Then we have the picture of the typical vasculitis, because the underlying cause is always the inflammation of the vascular tissue. Next, we have the sweet syndrome. Sweet syndrome is characterized by sudden onset of both fever and painful rash, and it is usually found after patients who have been immunized or have just received a vaccine. But in this case, because it has an antibody component to it, sometimes patient also present with the sweet syndrome. Then we have the pyoderma gangrenosum. Pyoderma gangrenosum is a inflammatory condition, whereas various type of group of pustules starts to form. Now again, it must be noted that this is a condition which is not infectious. So again, it is not contagious, and it is usually treated with conventional treatment. Now, and this condition usually happens because Behcet's is both autoimmune and autoinflammatory. So this condition is due to the autoinflammatory changes that are happening inside the skin. Next, we have general skin inflammation. Sometimes, instead of all of these manifestations, patients usually present with simple skin inflammation. That is, skin is red, it is itchy, with a well demarcated rash, and these other more severe or more complicated or well described manifestations do not appear. Next, we are going to study about the ocular manifestations. Ocular manifestations are important because, first of all, the symptoms of both scarring on the sclera or the cornea, along with bilateral panuveitis, that the uvea of the patient starts to show the signs of inflammation. These both signs can lead to a patient suffering from blindness. And if it goes untreated, it can result in permanent blindness. So, any ocular manifestation in Behcet syndrome, either it's early or late stage, must be treated as soon as possible, because there is a huge chance of patient developing blindness. And sometimes, instead of the usual scarring or panuveitis, we also get some other symptoms, some other uncommon symptoms like the iritis, inflammation of the iris, or optic neuritis, posterior uveitis. Instead of the whole of the uvea is involved, only the posterior section is showing the signs of inflammation. Or we get the retinal vessel occlusion. Now, in the case of the retinal vessel occlusion, the symptomology differs a little and usually can only be found on fundoscopy. Next, we're going to study about the joint manifestations. The joint manifestations usually present in about 50% of all patients, and they are usually limited to only non-deforming arthritis. Now, the point non-deforming here is important because most arthritis in an autoimmune disorder usually result in a deforming type of arthritis. But in case of Behcet's, the arthritis is non-deforming. The hands and the fingers do not undergo any kind of deformity. So this is an important point to keep in mind. And the other symptom that we usually see is the arthralgia, the pain in the joints, and it is usually very common among the patients. Next, we're going to learn about the vascular manifestations. And these vascular manifestations are important because, one, like I said, the primary lesion is always a panvasculitis lesion. So, because the vascular bed is more involved in Behcet syndrome, we usually get a deep vein thrombosis or DVT in about 30% of the patients. And DVT, if goes untreated, can result in acute limb ischemia or even the pulmonary embolism. In either case, it must be treated as an emergency, and low molecular weight heparin must be given to treat it. The other symptoms that are usually uh, associated with Behcet's disease are the obstructive vena cava. It can also, like I said, present as a pulmonary emboli, even though chances are very rare. Now, these were all the venous side of the vascular manifestations, and they are about the 30% in all of the patient. The arterial manifestations, like uh, aortitis, that is inflammation of the descending aorta, or it could be arterial thrombosis, or even peripheral arterial aneurysm. All of these arterial manifestations are uncommon and usually found in about only 5% of the patients. Next, we're going to talk about the pulmonary manifestations in the Behcet syndrome. The pulmonary manifestations are one, the vasculitis, due to the infiltration of both the neutrophils and the accompanying helper and cytotoxic T cells, can result in vasculitis and the expansion and inflammation of the vasculature of the lungs. And this usually presents as both dyspnea, like the shortness of the breath. It can present itself as cough, and that cough is usually dry cough, non-productive cough. It can present itself as chest pain, because again, the pain in the lungs can migrate or even radiate towards the chest area or the anterior thoracic wall, or it can present as hemoptysis if the infiltration is to such an extent that it has started to damage the vessels and blood has started to leak into the airways. The other common manifestation, the clinical manifestation, are the infiltrates that are found in the chest. And these infiltrates are again due to the infiltrating neutrophils. Now, these infiltrates, when viewed on a chest x ray, must be differentiated either by physical exam or by high resolution CT scan, whichever is available or quick. It must be differentiated from the thromboembolic infiltration, because the treatment changes with it. Because in this disease, we give anti inflammatory agents, but if it's in a thromboembolic event and infiltrates are due to that, we give antithrombotic therapy. So we have to differentiate that what kind of infiltrates are showing on the chest X-ray and how to distinguishing them from the manifestation of the Behcet syndrome. Next, we're going to talk about the neurological manifestations. Neurological manifestations in Behcet's are rare, but they carry a very bad prognosis, because it is usually of the parenchymal nature. About 80% of the all manifestations are of parenchymal nature, and it affects both the midbrain and the hindbrain, including the brainstem. So when the brainstem and the midbrain, both of these are involved, this results in a symptomology that is both progressive, rapid, and can result in a variety of symptoms leading to both rapid decrease in the quality of the life of the patient and increased morbidity of the Behcet syndrome. But during evaluation of the cerebrospinal fluid, we usually find that there is heightened or elevated level of the interleukin 6. And this gives us a very clear idea that the patient has CNS manifestation of Behcet's. We also sometimes find cerebrovenous thrombosis, and this cerebral venous thrombosis is usually found in either in the superior sagittal sinus or in the transverse sinus. And this usually results in the blockage of both the drainage and the circulation of the CSF, resulting in a headache, sometimes migraine, sometimes both with or without the aura. The other symptom that we usually see is again due to the blockage, and blockage is again due to the thrombosis. We also get increased CSF pressure. So, if we suspect CNS symptomology in a patient with Behcet's, we perform a spinal tap where we take some spinal fluid of the patient, analyze it, and the patient has increased intracranial pressure, has elevated amount of interleukin 6, then we can easily diagnose the patient with this having CNS Behcet's syndrome. Next, we're going to study about the gastrointestinal manifestations. And these manifestations are important because, like I said, Behcet's results in ulcerations. And these ulcerations are usually found on the mucous membranes. And whole of the intestine, the lumen of the intestines, is a mucoid area full of mucocutaneous surface. And whenever a patient is suffering from Behcet's, ulcers can not only appear on the oral and genital area, but it also can occur inside the intestines. And these ulcers are sometimes indistinguishable from the ulcers which are usually presented in other diseases such as the Crohn's disease or the ulcerative colitis. So, an uh, endoscopy must be performed on a patient with Behcet syndrome presenting with gastrointestinal manifestations, because these ulcerations can be either from the Behcet's or it can be due to the Crohn's disease. In either case, our choice of treatment changes. So, any person with gastrointestinal manifestation has to have an endoscopic procedure in order to differentiate the etiology of these ulcers. Next, we're going to talk about the genital manifestations. Like I said before, that even though the rate of incidence in both the male and the female population is equal, males are more prone to having a severe manifestation of the Behcet syndrome. And this is due to because men have the testicles, and testicles usually present as epididymitis. The edematous of the patient shows signs of heightened inflammation, which is both painful and characteristic, along with the ulcers in the mouth of the Behcet's syndrome. Now, usually the females do not get the genital manifestations because one, labia does not has any ulcerative manifestations, and the scrotal ulcerations usually heal on their own. So the genital manifestations are usually only limited to either to the epididymitis or to the scarring and ulceration of the scrotal sac. Next, we're going to talk about the laboratory findings in a Behcet syndrome. Now, a patient with Behcet syndrome if we perform laboratory test on them, usually we find leukocytosis because again there's increased migration of neutrophils. We find that there's elevated ESR because again it's an inflammatory disease, so the ESR or the erythrocyte sedimentation rate increases, and we find increased level of C-reactive protein, and C-reactive protein increases in every inflammatory disease. So these are the typical findings in any person suffering from Behcet syndrome. Next, we're going to talk about its diagnosis. Now, its diagnosis can be done either by imaging or by physical exam. Through imaging, it can be done through MRI or magnetic resonance imaging, in which we study the ulceration of the patients in all the areas of its manifestation. Either it's the oral cavity, the genitals, the eyes, the GI tract, wherever the ulceration is, there is inflammatory process happening, and inflammation is always followed by edema. And MRI is kind of the study which reads the protons which are found in the water molecules. So more the inflammation, more the edema, more the water is present at the site, and more the MRI is sensitive to finding these symptomologies and manifestations in the patient. But nowadays, there's another test that is taking place in place of the MRI, that is the magnetic resonance spectroscopy. Now, both have the same fundamental principle, that they look for the protons that are found in the water. The only difference is that in spectroscopy, we perform a localized exam. Now, MRI examines the whole of the body and the water contents of the whole symptoms. But in spectroscopy, only a localized area known as voxel is studied. And when we only study a localized area, we can also study its metabolism and what kind of metabolism is taking place, if it is heightened, if it is lowered, if there is some kind of metabolites that are specific to it that are taking place in the reactions. And this study in Behcet syndrome is usually reserved for patients suffering from CNS Behcet syndrome, because in CNS Behcet syndrome we have to look at the changes that are found in the brainstem. Now, CSF changes are again found out on the spinal tap, but the changes in the brainstem, all the inflammation and the edema, that can only be precisely found through spectroscopy. So that's why spectroscopy is the method of choice for imaging in patients with CNS manifestations, and simple MRI is the imaging of choice in patients with other manifestations. Now, as I said before, Behcet's can be diagnosed both on the imaging and on the physical exam. Now, when performing the physical exam, it has a certain rules and guidelines. And these rules and guidelines are that patient must have recurrent oral ulcerations. You cannot diagnose a patient with Behcet's without this symptom. So this symptom must be present if you want to follow the guidelines for the diagnostic criteria. Next, any two of these, if they are present along with oral ulceration, then we can easily say that patient is suffering from the Behcet syndrome. Now, these can be genital ulceration, they can be eye lesions, they can be the pathology test that is the subdermal injection of the normal cell line, and if rash develops, then we say that the pathology test is positive, and it is only positive in pro-inflammatory conditions or when there are skin lesions. So if only two of these are found along with oral manifestations and ulcerations, then we can easily say that patient is suffering from the Behcet syndrome. Next, we move on to the treatment of the Behcet syndrome. Now, for the Behcet syndrome, our first choice of drug is topical glucocorticoids, because Behcet syndrome commonly only manifests itself either as oral ulcers or genital ulcers. So, topical steroids help not only in quick remission of the disease but also result in less scarring of the ulcerations. Next, if topical glucocorticoids are not enough, then we move on to a more anti-inflammatory drug, that is the thalidomide, and it is given in the dose of 100 milligram per day in divided doses. And again, it has an anti-inflammatory effect. It suppresses the formation of new ulcers, uh, give way to the remission of the old ulcers, and reduces the scarring. And it is usually only given to the patients who do not have the aphthous ulcers but have more of the herpetiform ulcers, because herpetiform ulcers not only are extensive, large in size, but are more prone to having necrotic and gangrenous tissue to them. So, in order to counter them, we have to give a stronger anti-inflammatory agent, which in which this case which we give the thalidomide. The next drug of choice is the aspirin, and aspirin is given in 325 milligram per day in divided doses. Now, aspirin is given only to the patients showing sign of thrombophlebitic symptoms, that both the veins of the patient are showing signs of inflammation or the patient is showing the signs of typical vasculitis. So in all those patients, along with topical glucocorticoids or the anti-inflammatory therapy, we also add the aspirin in order to counter all the inflammatory changes taking place in the vascular bed. The next drug is the colchicine. Now, colchicine is a drug which inhibits the motility of neutrophils, and it inhibits the migration of the neutrophils to the site of the inflammation. Now, when their migration to the site of inflammation is inhibited, the chemokines are not released. So, as a result, the pathogenesis of the Behcet syndrome is halted and patients start to go into the remission. And in order to even start up the treatment of the patient, we can even give topical steroids along with colchicine. And colchicine as a drug with the severe manifestation of the Behcet syndrome is reserved with those patients presenting with either arthritis or with arthralgia or any other kind of joint inflammation. Next, we're going to talk about the systemic glucocorticoid therapy. Now, systemic glucocorticoid therapy is given to those patients which have high morbidity of the Behcet syndrome. So instead of giving the topical steroids, we give intravenous systemic glucocorticoids. And the glucocorticoid of choice is prednisone. And prednisone is given as 1 milligram per kg of body weight per day in the patients with Behcet syndrome. Now, another component of Behcet syndrome, along with its inflammatory changes, is its autoimmune component. Now, in order to counter the autoimmunity in Behcet's, we give immunosuppressive agents. Now, the choice that we usually give to the patient is the azathioprine, which is given in about 2 to 3 milligram per kg of the weight per day. But sometimes azathioprine is not enough. It is usually either combined with cyclosporin or given is neglected and given only the cyclosporin component, because immunosuppression is vital to the treatment of the Behcet syndrome, because we not only have to deal with the anti-auto inflammatory changes but the autoimmune changes in the patient. Now, there are also certain other trials that are happening for the treatment of the Behcet's, is that the patients are receiving anti-tumor necrosis factor antibodies, and these are showing very promising results, and patients with even advanced stages of Behcet syndrome are showing signs of remission. The only problem is that this treatment is in its trial phase, but is showing potential, and maybe in few years might be available in market, and you might be able to treat your patients with Behcet syndrome with anti-tumor necrosis factor antibodies. So this was the lecture on the Behcet syndrome. Behcet syndrome, like I said, is also known as the Silk Route syndrome, because it is found usually around the areas of the Mediterranean, the Middle East, and the Far East. And it is usually manifested in oral ulcers, in genital ulcers, along with the eye manifestations, the GIT manifestations, and the pulmonary manifestations. But in some patients, we also get the venous, the arterial manifestations, of which only the DVT is more important, because DVT can result in pulmonary embolism, which can be fatal and must be dealt with as early as possible. Then we also studied about its diagnosis. We studied what is the diagnostic criteria during a physical exam. We studied what imaging can be done in order to diagnose the Behcet's disease. That what is the role of the magnetic resonance imaging, what is the role of the magnetic resonance spectroscopy, how they're different, and why during the CNS manifested Behcet syndrome we prefer spectroscopy instead of regular MRI. We also learn about the guidelines of the Behcet syndrome, that the guidelines state that we need to have recurrent oral ulcerations which are pathognomic for the Behcet syndrome. And along with these, either we can have genital ulcers, we can have the pathology test, we can have eye lesions. Either two of these, along with oral ulcerations on a physical exam, can give us a differential diagnosis which is more prone towards the Behcet syndrome. And along with its diagnosis, then we learned about its treatment. Now, treatment of the Behcet's, like I explained before, moves along with the severity of the Behcet syndrome. For the patients with only oral and genital ulcerations, we give topical glucocorticoids. With severe ulcerations, if there are some kind of gangrene or necrosis, we give thalidomide. If the patient is showing sign of thrombophlebitis, we give aspirin. If the patient is having frequent attacks of the Behcet syndrome, then we give colchicine to inhibit the migration of the neutrophils. Or if the patient is having less of the autoinflammatory changes and more of the autoimmune changes, then we start to give the immunosuppressive agents. The primary immunosuppressive agent in Behcet's is the systemic glucocorticoid therapy along with the azathioprine. But sometimes in the advanced stages, it is not enough. Then we do cyclosporin along with azathioprine or increased doses of cyclosporin with azathioprine. And I also mentioned about the trials of the anti-tumor necrosis factor antibodies, which are showing huge promise to the patient of the Behcet syndrome. And as they are in trials, patients are receiving them. In a few years, they might be available in the market. So this was the lecture on the Behcet syndrome. Thank you so much for watching sqadia.com.